Lovely. Well, thank you everyone for joining us for the second session of the Victorian Hospital in the Home Clinical Grand Rounds that we've started across Victorian medical leadership. I'd like to just respectfully acknowledge the traditional custodians of this land, the people of the Kulin Nations, and we pay our respects to their elders past and present. We acknowledge and uphold their continuing connection to land and waterways. Thank you so much for joining us from all over Victoria, and I know that a number of people are keen to access the recording today as well, so this is being recorded. We're very lucky to have Andrew Fuller, who is the head of the Hospital in the Home program for Alfred Health, as a leader in hospital in the home for many years here, presenting to us on the use of antibiotics in hospital in the home programs, and sharing with us some evidence and his experience with this. I hope this will be a really great session for everyone. It has lots of relevance for us all working in this space. Happy for you to pop any questions in the chat as we go or raise your hand, but I think what we'll aim to do is for Andrew to present, and then we'll do a session of questions at the end, and I'll keep an eye on the chat for that. So without any further announcements, thank you, Andrew.
Okay, thanks. Look, some of this talk I've given before, but I'm going to go through some of the history of how hospital and home started at the Alfred Hospital. Hang on. So we started about 1994, initially for cystic fibrosis and osteomyelitis patients, and then we built up, got our own nurses and cars, and we visit patients up to 40 kilometres away, but we also outsource to the whole of Victoria because we're statewide services. And our definition of hospital and home is without these services, the patients would otherwise need to be in hospital. And over the years, patients have become more and more complex, and they're sent home earlier than they used to be, and there's huge bed pressures to get people out. And so these are our sort of numbers over the years, and you can see that the age goes up to 101, 63% are male, and people are on hospital and home for about 11 days on average. So it's quite a significant amount of time, and mostly it's for antibiotics. This is an old graph, but mostly it's for antibiotics, but lots of other things go on to hospital and home now. And you can see it's up to about 2009, everything plateaued, and it's really continued on much the same level for those years. So these are sort of basically what we do for antibiotics. For streps, we use cefazolin. For staph, we use cefazolin. For MRSA, vancomycin. Pseudomonas, it's often cefepime together with Cipro. But we have used lots of other antibiotics. Just about everything that you can use in the hospital, you can use at home. We use Baxter infusers and CAD pumps for drugs that require more than 2 doses a day, and we do a whole lot of different antibiotics. So this is just to get things in perspective. With the first 100 patients we had, a lot of them were CMV with ganciclovir, and MRSA with this is going back to the 90s. And then by the time we got to the year 2000, the CMV had dropped off, and what had increased is the streptococci. And this really led to the next thing, was that cefazolin became a bit of a workhorse, because previously cefalothin was the antibiotic we had in most Victorian hospitals up until 1995 or 96, and then cefazolin came along and had a longer half-life, so it became a bit of a workhorse. And you can see that by 2009, 34% of patients were on cefazolin, and that's just basically continued because of its long half-life. So you can see every other antibiotic on the list there is being used. And so talking about some protocols, so cellulitis, when I was a medical student, we treated, and a registrar, we treated cellulitis with penicillin in the hospital if it looked streptococcal. In fact, 90% was streptococcal. And then we didn't, and then in about 95 or 96, flucloxacillin came on the therapeutic guidelines. And now hardly anyone uses penicillin in hospital. It's usually fluclox or cefazolin. And for home treatment, we prefer cefazolin, and we can go with our 40-kilometre zone. We can go twice a day to the patient. So, and we use 2 grams twice a day, and we find that works much easier. We used to use once a day with probenecid, but we had too much. We had about 40% incidence of nausea, so we stopped that. And these cellulitis patients are often given by a peripheral line, and then it's usually 5 to 7 days, and they're onto something oral. For septic arthritis, again, for ease, we use cefazolin, 2 grams twice a day for 2 to 3 weeks, and for that you'd need a PICC line. And if it's MRSA, we would use vancomycin. And for gram negatives, we might use ceftriaxone or cefepime for septic arthritis. For osteomyelitis, again, our workhorse has been cefazolin, 2 grams twice a day, or if they're over 80 kilograms, we use 3 grams twice a day. And this has been quite successful in our hospital home patients for osteomyelitis of long bones, vertebral osteomyelitis and sternal osteomyelitis. And we usually go between 4 and 6 weeks, and then we may need an oral tail in some things like vertebral osteomyelitis. And I guess depending on what the bug is, we may use vancomycin, ceftriaxone or cefepime. Staph septicemia, again, we tend to use cefazolin, 2 grams twice a day. Now, I guess we have used flucloxacillin. We have used it with a CAD pump. We have used it with a Baxter infuser. But the side effects of flucloxacillin are quite significant. 2 or 3 times a year, we see someone with renal or liver problems. For endocarditis, I guess we find it easier for streptococcal endocarditis, strep bovis or strep mitis endocarditis to use ceftriaxone. It's a lot easier for nurses coming to the home. You can use penicillin, but it's awkward. It's awkward and more expensive, especially to be hooked up to a CAD pump or to a Baxter infuser. It's much easier to have your arms free. For staphylococcal endocarditis, we again visit twice a day and use cefazolin, 3 grams twice a day, or occasionally we use a pump. Now, urinary tract infections, it's been very rare to treat these on hospital home because there are many good oral antibiotics such as quinolones, which are as good as intravenous treatment. Pneumonia, it's been quite rare to treat pneumonia at home too, but we do use it for some patients. So this is straightforward stuff. The general principles of treatment should be to select the appropriate antibiotic as per the micro results, have good access, follow up, and we try and follow the therapeutic guidelines. But here are some things we don't do. We don't use ceftriaxone for cellulitis or as a staph drug. So we don't do that. We try and preserve ceftriaxone like we do in the hospital situation. We don't use IV Cipro, fluconazole, azithromycin, moxifloxacin, clindamycin, doxycycline, cotrimoxazole, fusidic acid, rifampicin, or linezolid, because all of these can be used orally, and oral equals IV for all of these drugs. And we seldom use constant infusions of beta-lactams or vancomycins. This is what we do at the Alfred. And you can see over the years, our infections have all fluctuated, and really that's old data, but even now it's much the same. We have the statewide cystic fibrosis adult patients, and these patients are on hospital and home for about 21 days for a tune-up every year, maybe once or twice a year. And these are a unique group of patients that are young, and they can be taught to give their own antibiotics, which is great. So this is what they do. They usually give their own tobramycin with either one of tazocin, ceftazidime, cefepime, meropenem, and that's usually all self-administered, which is really easy. In about 1995, 1996, we started taking direct admissions from ED or daycare, and initially it was 6 per month, and now it's gone right up to much higher numbers because it's quite hard to get. Now it's about 12 a month. It's quite hard to get a bed in the hospital now, so for a lot of patients, it's a matter of booking a bed in a daycare area getting the PICC line and getting them on treatment. That would be specifically for things like osteomyelitis. I'm just going to throw in a few cases as we go. This is an unusual cellulitis. A 39-year-old man presented to casualty with fevers and rigors and cellulitis over his right shin. We gave him intravenous kefazoline. He continued to have fevers, however, and we had to drain his collection. And I'll show you a photo of his cellulitis. This is a bit unusual. We had to drain pus out. And it really, once we drained the pus, his fevers settled. We grew group C streptococcus. We're seeing more group C and G now, but in the last 5 years, we've seen a huge surge in group A strep. So this guy went on and had a bone scan, but you can see quite nicely down the bottom there that there's a collection there, and this is the flow study, but there's nothing in the bone at all. And once we drained him, he continued with kefazoline and he got better. So it wasn't a kefazoline failure, it was just a failure of draining the pus, really. Here's another patient. It's interesting. This is a 48-year-old wharfie who had elbow pain and fevers after returning from a holiday in the Philippines. And he admitted to having sex once without a condom with a local lady. And he came in with his sore right elbow. He had high CRP and white cell count. He had intravenous penicillin. Then he went home on kefazoline, and he was no better. And so this is a photo of his elbow, and we aspirated his elbow, and this was really quite inflamed. This is a tattoo that he had, and the cellulitis had almost resolved, but the joint was still painful. So it was quite clear that the problem was septic arthritis and not cellulitis. And in fact, the bone scan showed this quite nicely. On the flow study, there's not much to see, but on the bone study, you can see quite a rip-roaring joint infection. And I guess you could all guess what we found. We found that he had gonococcal septic arthritis. And of course, kefazoline doesn't cover, so we changed to ceftriaxone, and he did really well. And he had acquired this from a prostitute, but fortunately he did not get HIV. So ceftriaxone has been our workhorse for gonorrhea, septic arthritis, and we have maybe 5 or 10 a year of those. But osteomyelitis is much more common, and as you can appreciate, often patients have osteomyelitis and have nothing on their x-ray. So this lady here, she had quite a sore toe. There wasn't really much to see on the x-ray, but on the nuclear bone scan, you can see that toe lights up quite nicely. And she grew pseudomonas, so she was treated with cefepime 2 grams twice a day with twice daily visits, which meant she didn't have to be hooked up to a CAD pump or a Baxter. And then she went on to ciprofloxacin, and she did well. Here's another case of osteomyelitis due to MRSA, and we are seeing more and more community strains of MRSA now. In the suburbs of Melbourne now, Dorevitch and Melbourne Path, their rates are above 10% now, probably 12%, I think, of cases now of positive swabs. So it is on the rise. And this patient had a right foot ulcer. Again, you can see on the bone scan that there's infection in the bone. And this lady was treated with vancomycin for 4 weeks, and then oral clindamycin, to which she was sensitive to. And we followed her vancomycin levels once or twice a week, and then we went to clindamycin, and she did well. This is an unusual case. This is a lady who's quite young who had a swollen knee, and it was quite painful. And what was aspirated from her knee had polymorphs in it. No organisms were seen, and the Staph aureus did not grow for a good week, and which was a bit strange. and I wondered why. She was treated with cefazolin. Her CRP and white cell count and ESR all came down quite nicely, but the knee remains sore. And so on nuclear scanning and MRI, you can see that in fact she has got a Brodie's abscess. You can see that in the femur there on the MRI on the right, and on the left you can see it on the technetium bone scan. And so the infection is actually in the bone and it's spilt over into the joint, which is why it wasn't much of the staph in the joint. So we changed her to 6 weeks of cefazolin and she did well. So we have looked at our patients with osteomyelitis, and we found very high cure rates with cefazolin twice a day. And this is presented at a meeting in 2007. And we've also published our cefazolin for severe, serious methicillin-sensitive Staph aureus infections. This is 3 grams BD again with twice daily visits. And again, we had a very high cure rate, and no cases of antibiotic failure were identified. So this was published in 2019. So this is, cefazolin has been our workhorse for these reasons. And we measured levels in a few of these patients and found that the trough levels were well above the MIC. We get a lot of base of skull osteomyelitis also, and this is a lady with a chronic ear discharge who had fevers and headache, and you can see she's got opacification on the right side there, and in fact she's also got sagittal sinus thrombosis, which you can see at the bottom right. We grew Staph aureus from her ear, which is a bit unusual. Normally basal skull osteomyelitis should grow Pseudomonas. In fact, in one of the studies we published, 75% were due to Pseudomonas, 25% and about 20% were due to staphs of different sorts, and a small percentage were due to fungi like Candidas and Aspergillus. This is taken from ear swabs. So she went ahead and had a mastoidectomy, and she had flucloxacillin. We gave her, we did this via a pump, via a CAD pump, and we had to give a GCSF because she got some neutropenia. And we also gave her some ceftriaxone as well, in case she had gram negatives, but we stopped that after a while. And we had to treat her sagittal sinus thrombosis with Clexane warfarin, and she did well. Vertebral osteomyelitis is also reasonably common. We have about maybe 1 or 2 a month, and the presenting features are pain and often fever. And then on MRI, you can really see that you have a joint disc infection, and you have the end plates above and below that are infected. And this is a classic sort of MRI for vertebral osteomyelitis. It's great when you grow something in the urine or the blood, like this patient did. Then you don't have to go ahead and biopsy them. But if you don't grow anything, then you may have to go ahead and biopsy them, usually under the CT scanner. The pickup rates are quite low. They're about 10, 20%. So a lot of the time you're left with just empiric treatment, which is what we do sometimes. So this patient took a long time to settle. He was treated with ceftriaxone because of the E. coli. He settled. It took a long time, and then he went on to ciprofloxacin. And he was very slow to improve, but with follow-up and all the rest, he did great. He did well. Now, endocarditis is a common thing. We do about 1 or 2 a month of these. This is a case of an interesting one, a lady who was driving down Punt Road, and all of a sudden her right arm went numb and painful. So she drove into the emergency department, car park there and hopped out and came inside, and she had no pulses. And so she had a quick angiogram, which showed that she actually had a complete blockage there in one of the arteries. And she went to theatre and they took out this embolus, which grew Haemophilus parainfluenzae, which was a bit strange because that's one of the HITH organisms, which then led to someone listening to her heart to see if they could hear a murmur, which they thought they could. So she had an echo, and this, no, this echo's not playing. That's annoying. Anyhow, but she had a large vegetation. So she had to have surgery on the vegetation, and she had 6 weeks of ceftriaxone, and she did quite well. We do see a lot of endocarditis. Prior to recent times, we would not take, prior to COVID actually, we would not take intravenous drug users on at home for home treatment, but we do now. But this lady was several years before. This is probably 2017, this case. And she came in with pneumonia, and you can see on the X-ray that there are some peripheral patches, which are much clearer to see on the CAT scan, and she grew Staph aureus in the blood. And even though she said she hadn't used, I'm sure she had, and she had tricuspid endocarditis, and with seeding of her lungs from emboli. And she had multiple tricuspid vegetations, and she was treated with flucloxacillin 2 grams 6 hourly for 4 weeks, and came good. In the last few years, none of these antibiotics are new, but they are newish to hospital and the home. Ertapenem, tigecycline, daptomycin. Our experience with ertapenem started in 2006 with 1, and then 2007 with 3, 2008 with 9, and 2009 with 20. And now it's quite a common drug on hospital and the home. But we reserve it for ESBL or Serratia, these sort of bacteria. So we try not to use it for the standard things. And you have to know that ertapenem, it's a pretty good carbapenem, but it doesn't cover Pseudomonas. So it's, and even if we've got an organism like Enterobacter in the blood, for instance, we have to do an E-test to make sure it's ertapenem sensitive. E. coli's usually are sensitive, but sometimes you find that a bug like Enterobacter will be sensitive to meropenem but resistant to ertapenem. So it's always important to do an E-test. This is what we've used it for, mainly ESBL, E. coli's, but also Bacteremia, osteomyelitis, and septic arthritis with organisms that are fairly resistant. So that's sort of the rules with ertapenem. Tigecycline, this is probably one of the first patients that we treated with tigecycline. This is the Mayor of Bendigo who had an infection after having clamshell operation for his lung transplant, and he grew Mycobacterium abscessus in many different areas, and you can see the organism there, and this is it growing on an agar plate. And by this stage, it was quite resistant, and so we had to use tigecycline. We also combined that with cafoxidin and amikacin, which we did for him, and he was finally cured and had no side effects. But this is what had to be done. We had to cut it all out basically, because surgery is part of the treatment for a lot of Mycobacterium abscessus infections, especially when they're very resistant to the standard treatments. So he did well in the long run, but this is a unique sort of problem, Mycobacterium abscessus, and we would have 1 or 2 on our hospital home program at any one time, with being on either cafoxidin or amikacin or tigecycline, these type of drugs. They're usually on other things like oral clofazimine and azithromycin. Daptomycin, it's it's a really good drug for MRSA and MSSA. I guess we do use quite a bit of daptomycin for VRE now, and this is a patient who had base of skull osteomyelitis, actually in a different place rather than in the petrous temple bone. This is more in the front, and she was treated with daptomycin and did well. And then in recent times, we've had all sorts of other things that have cropped up. Syphilis has taken off in a big way in the last 10 years, and we would have someone being treated for neurosyphilis on our hospital home every one a week almost now, and usually in the gay men, but we are seeing it crossing over to the heterosexual population. This is so these patients would have started off in hospital, and then they go home with a CAD pump, and we use a 250 ml bag of normal saline with 6 grams of benzoyl penicillin, and we use sodium citrate as a buffer. And we have measured the blood levels in these patients and found that at the end of the bag, the levels are pretty decent. And we change the bag twice a day. So sometimes we teach the patient to put the second bag up themselves. Take it out of the fridge. And we've gone for a slightly higher dose of 2 rather than 1.8 grams to allow for a 11% degradation rate. And this works quite well. We haven't had any failures, and it's been very effective for our neurosyphilis patients, and they're treated for 15 days, usually with a CAD pump. Baxter infusers, we don't use that many Baxter infusers, but when we had problems with CAD pump lines in the last few years, we used a lot of these. They are much more expensive. Certainly they're common in the country, or we use them also if patients are unable to manage the CAD pump, because CAD pumps with a bum bag that you have to wear weighs about 2 kilograms, and we always have to worry about little old ladies falling over and hurting themselves with these heavy items on them. These are some other rare infections. This is an nocardia cerebellar brain abscess where we used ertapenem in the country because we couldn't use meropenem. And that patient did well with ertapenem for 8 weeks. This is a patient with tigecycline for New Delhi strain of Acinetobacter that was quite highly resistant, who did well with tigecycline. And this is one of my patients with HIV who'd been bitten by a sandfly in South America and had leishmaniasis, and we treated him with ambisome on hospital home for 5 days. We use ambisome, but so expensive ambisome that it has to be made up each day in the pharmacy and taken out by the nurse each day. We have had problems with expensive drugs being lost in the past, so we don't allow people to have ambisome if they're outsourced. Now, antifungals, we use a lot of caspofungin, anegofungin, and micafungin. Micafungin doesn't have to be put in the fridge, so it's useful for a patient in, say, with candidemia, Candida glabrata infection, who lives up in Echuca or something like that. Antivirals, we use acyclovir for herpes and encephalitis. Ganciclovir and foscarnet we've been using for many, many years for CMV. Ceftaroline for MRSA. Well, I have to tell you, we've sort of stopped using ceftaroline now because 50% of MRSAs are resistant. The newer ones here, ceftazidime avibactam and ceftolozane tazobactam, these are good for resistant Pseudomonas and for CREs and CPEs, but they're horribly expensive. The ceftaz avibactam one is not stable, so we were going to use it with an ice pack around it, but it's not stable at 37 degrees. It is stable for 12 hours, but not 24 hours. I know Baxter do offer this. No, they don't offer this drug, sorry. But we have done this one. And ceftolozane tazobactam is more stable, and that's about $900 a day. And I know if you want to get a Baxter with that, they add another $300 on that. And Cefetoracol, we've done that as well for very resistant bugs. Meropenem, patients, as I said, our CF patients give themselves 8 LD doses. If patients in renal failure, we can go twice a day or once a day. Otherwise, we have done an ice pack around the CAD pump, around the bag to keep it cool. And we've done that with ampicillin as well. Ampicillin is not particularly not as stable at high temperatures as penicillin is. This is a good article I found recently on stability of antibiotics, and it's worth looking at this to see what's stable and what's not. And yeah, so that's interesting, but it's more and more antibiotics now being used at home. So I guess the main issues are when patients do go home, they've got to want to go home, they've got to be on the right treatment before transferring to hospital and home. And I think it's up to us to do antibiotic stewardship as well to make sure the patients are on the right antibiotic for their home situation. So I might stop there if anyone's got any questions.
Thank you, Andrew. There's a couple of questions in the chat, and if people want to pop their hand up and either ask them, are you able to see them, Andrew, or do you want me to read them out?
Am I able to see the chat?
I can read them to you.
I have found the chat. First one from Arkar about BD cefazolin. Okay, so what Arkar is talking about there is whether BD versus constant infusions. Look, constant infusions are great if you know that the levels you're getting at the target site are going to be adequate. But I'll just tell you where I think this falls down. There are a couple of areas where it's quite hard to penetrate, and that includes bone, the brain, and the eye, and the prostate. So they're all hard areas to penetrate. And my belief is that constant infusion cefazolin doesn't get quite high enough levels to get into bones sometimes. And that's why I think there's a failure rate of 15% for Baxter infusers, I think, in constant infusions. So that's why we don't use as many of those. And I won't treat endocarditis as well. That's another difficult area I'll try to use a CAD pump. So we get peaks and troughs, and none of this has actually been studied properly. And I think it would be good doing a trial, Arkar. I think it's a great idea. And Michael Montalto, you've written, Andrew, we use ertapenem quite a lot too. Note a very high rate of hyperactive delirium. Yeah. So look, Michael, we've noticed the same too with ertapenem. Imipenem used to cause fits and all sorts of things. We do use imipenem sometimes. Ertapenem causes fits too. We've had a couple of people fit. And I think if you're having failures from ertapenem, it could be because the bug is resistant, and that's why you need to do that at MIC, I think. Anyhow, these are just my thoughts. Any other verbal questions?
Can't see any hands up there. Everybody's a little bit shy, maybe.
You know, I think what we do at the Alfred is going to be different to what everyone else would do around the state. And I think in general, the country hospital homes will be using Baxter's pretty well all the time and mostly having good outcomes. And I think there are many hospital home area services that can only visit once a day. And I know, Michael, you like your CAD pumps, and I know the the CAD pumps are pretty good. They have their downside because they're heavy and burdensome, but they are useful.
Coming back to the question around stewardship, Andrew, do you want to tell us a little bit about how it works for your service around decisions around antibiotic regimes from the inpatient units versus suggestions from HITH about what would be appropriate, and how often do you need to change what's suggested or alter it to suit hospital in the home?
Well, mostly our patients in the ward, for instance, have had an ID referral and they're kind of on the right antibiotic, but sometimes I'll change them. An example could be with vancomycin, for instance. Sometimes if you're looking at someone who needs a CAD pump with vancomycin is a bit of a nuisance drug, actually, if you have to give it 2 or 3 times a day, and then you have to do levels all the time. So there are patients where we've just simply swapped to ticaplanin. Now, ticaplanin's a lot more expensive and you've got to load it, but you've got to load vancomycin in the first place too. But sometimes once daily ticaplanin is our way out when a patient lives a long way away, say down near Frankston or out in the country, and we're treating MRSA. So what we do simply with ticaplanin is 800 milligrams IV 12 hourly for 3 doses and then 24 hourly. So that's the loading part of it, which can happen in the ward. And we don't worry about doing ticaplanin levels. We've had good results with that. But ticaplanin has got its own problems. For instance, it doesn't penetrate vegetations at all. So if you've got treating endocarditis, you can't use that. The other things that I've had to change is some patients are on penicillin in the ward, and for say a streptomyces endocarditis, and we'll just simply swap them over to ceftriaxone daily, which I find a lot easier for the patients and a lot easier for the staff. I know it's not pure, but what we do at home isn't exactly what we do in hospital, and we just have to realise that's the way it is sometimes.
We have another question in the chat, which is actually for the broader group. I know I can see Cara and Siok and June online, as well as Michael, so a couple of different HITH services. Does anybody use ceftriaxone and doxycycline as a combination for cellulitis? What's been your experience with that?
Ceftriaxone, it's come from Akar Ong, who's Akar's an ID physician. I don't know if anyone using doxycycline, it wouldn't make much sense, Akar, to use that. You might use ceftriaxone and clindamycin. That would make more sense for group A strep, for turning off the toxin production.
Yeah, I think in the Northern European countries, I can't remember. I actually can't remember which country, but basically ceftriaxone and doxycycline is a recognized treatment for cellulitis regimen. I think there was a randomized control trial that has been published maybe about a decade ago or so. So I mean, I'm just interested because that's also a possible combination. It's a once daily combination. So
yeah, well, we wouldn't use ceftriaxone as a strep drug. We try and reserve ceftriaxone, or for cellulitis, I mean, we would use cefazolin twice a day. Would anyone else use ceftriaxone daily for a strep cellulitis? I know people do. Michael, would you do that?
Can you hear me?
Yep.
Look, if they're very elderly or they have very poor venous access, if they have, yeah, I mean, sometimes in those two circumstances, and it's pretty clear that it's likely to be streptococcal, we might do that, but usually we stick to the cefazolin BD regime.
Yeah, there are a lot of GPs out there that give their patients ceftriaxone every day for 5 days for cellulitis. That's a common thing in Melbourne suburbs. I mean, ceftriaxone, I have to say, at our hospital is not as restricted as it used to be. In the old days with ceftriaxone, going up to about even 10 years ago, 5-10 years ago, you'd have to get special permission to use ceftriaxone. And now that permission is not required anymore. So it is, but the more and more broad spectrum we go with our antibiotics, the more and more we drive the resistance with bacteria. So eventually we are going to see more and more ESBL and meropenem resistant CPEs and so forth, which are starting to crop up now. We're seeing CPEs cropping up in people that have never been overseas. Meropenem resistant organisms. So these things are starting to happen now. But mind you, they've been happening for a long time, for about 5 or 10 years in European countries like Greece and France and Italy. But we're starting to see it now. We're starting to see widespread resistance developing.
I can see IFTA online. I know the Hospital in the Home Australasian Society had a project to look at across all of the hospital in the homes, and especially looking at antibiotics. I think for cellulitis is one of the indications. IFTA, did you want to make a comment about that?
Sorry, I missed. Say it again.
IFTA's just stepped out. He's just got a phone call.
Oh, no worries. I was just asking Andrew, IFTA's one of from Eastern Health was running a project through the HITH Society around antibiotic use. I think just to sort of gather a bit more information around how we're all treating it across the state, rather across Australia, but it sounds like he's just on another phone call. It's okay.
Can I ask the group, has anyone used daily cefazolin with oral probenecid? No. Actually, it's quite hard to get probenecid now. Most of the local pharmacies don't stock it. We have used it a little bit. Actually, we use probenecid when we give people foscarnet, but the nausea rate's about 40% in my experience. So we stopped that many years ago. But it does work, and there's published. I know Lindsay Grayson published an article back a long time ago now, in the 90s, about cefazolin once a day with probenecid working, being as good as BD, cefazolin.
I can see Lydia Upjohn has got a comment.
No, we don't use it at Monash. People get too sick and from it, too much nausea, side effects.
Yep. At Monash, you use your own little Baxters. You make your own up, don't you?
We do. We have our own internal sterile pharmacy, so that is much more cost effective than Baxter's.
Yeah. I'm
and so
envious
that we
of you
use
for that.
mostly infusions.
Yeah.
Whereas you use the CAD pumps, including for neurosyphilis, benzylpen endocarditis most of the time. And we did a cost-effective study looking at IV benzpen infusions made up by us versus ceftriaxone once a day. I think ceftriaxone still won, but I tend to have a lower threshold for switching them to benzylpen infusion. So yeah,
Okay.
we have that advantage. It's good.
That sounds great. And Cara, you've made a comment that you do use it across at Eastern, but low threshold to change if not tolerated.
Yeah, I mean, there's times when obviously activity has been very high and capacity has been very tight. It's not a preference, and certainly most of our patients end up on BD or sometimes even TDS IV cefazolin. But there have been times where, especially during COVID, where it was very high pressure in terms of capacity, that we've used it for a select patients that are fit and tolerate it well.
Lydia?
No, I'm sorry.
Oh, sorry, Cara, keep going.
No, it's mainly to allow us to take on more patients. So it's not ideal practice, I guess, but judicious use of resources, I guess.
It's important as well.
Can I
Ready
ask
for
the
my
group
question?
about vancomycin at home and how often you do levels and whether you use it?
Michael said same as in hospital.
Yeah, we use it at home. We follow the same protocol as they would if they were in the bed-based unit. Levels as frequently based mostly on their renal function and dose accordingly.
Diak, did you have a comment?
We sort of swap our vancomycin regimen, I guess, based on partly on the 24-hour infusion based on the Alfred protocol, Andrew. So if we can do BD, then we do BD with trough levels every third dose if it's unstable. And then if we can't do BD, then we try and get them stable on a 24-hour infusion, which I think is the same as what's done in another Melbourne hospital. I guess really the question is, I'm not sure what the evidence base is with regards to random serum levels of vancomycin on a daily infusion. But if we can't do BD, that's what we do.
We used to use infusions of vancomycin, and we found that 50% of the patients, there was only 8 patients, but 50% of them went into renal failure. So we stopped doing it. It was a long time ago now. So we do go for the peaks and troughs, and I guess you can get renal failure anyway, but there has been a trend with vancomycin dosing to go higher and higher with the troughs. I remember, going back 30 years, we would be happy with a trough of 5, and then it went up to 7, then it went up. Now it's gone up to 15. We're all aiming for about 15 now. And that's because there's been MIC creep in all the bugs, MRSA in particular. And there's a bit of evidence to say that you, with a higher level, your patient's going to do better. But there's also evidence to show that the higher you go, the more likely you are to get toxicity. So you have to be pretty wary of that, I think.
That's right. And I mean, the other alternative of RIF and fusidic acid is not, I'm not sure whether it should only be classified as an outpatient therapy. I feel like it's HITH to administer appropriate therapeutic regimens, and it's oral. If the appropriate regimen is oral, and there's questions around monitoring of LFTs or supply or compliance, then RIF and fusidic acid orally might be appropriate too. And often clinician driven as well, I guess, if the clinician has experience with autotoxicity of vancomycin.
Yep. Hi, everyone. Just a comment about vancomycin infusions. So we use a lot of vancomycin infusions. We used to do trough monitoring, and then when we changed people from intermittent to infusions, we used to drop the dose by about 25%, because otherwise people would get toxic pretty quickly on an infusion. But then we changed over to dose-me dosing using AUC monitoring, which is really good for HITH because you can take a level whenever you want to, and you don't have to do trough monitoring. And we found that our dosing was much better, and we didn't have to do that 25% drop, and we're getting less toxicity. So that's been really good as well, using AUC monitoring. Thanks.
Oh, that's interesting. What level are you aiming for then?
We have a AUC range that we, just like you would a trough level range. So 400, 450. We have a range that we use. So, but that's been excellent.
I'm not familiar with the AUC calculations, but anyhow.
It's 400 to 600, and you put it into a Bayesian model, and it spits out. The pharmacist will put in you usually do it for us, and they put in the renal function and the weight of the patient, and then it calculates a recommended dose.
So that's a calculator, Lydia. DoseMe.
DoseMe is a program. It's a Bayesian dosing program that we use at Monash, and we've rolled it out over the whole of Monash for vancomycin. You can't use it in pregnant women. It's not validated for that. But there's other hospitals. I think Austin's just using it in ICU, and we found it much better in terms of avoiding toxicity for our HITH infuser bottle patients.
And Lydia, the amount of milligrams you're giving per day, or the grams you're giving per day, is less than.
Yep, it is.
It is,
yep,
right.
That's our impression. We haven't collected we're collecting the data on it to have a look at it, Andrew, but we're finding it's less than what we were giving before. Yeah.
And the patients are all getting better.
They're fine.
That's great. And do they have proven MRSA or something that needs vancomycin?
Yeah, usually.
Yep.
Yep. Deep-seated infections as well.
Might be something that we can
so I'd recommend it to people as a good thing for DoseMe treat. It's been really good for hospital in the home.
We've got a couple of our senior pharmacists online, so we might just
watch this space. We'll hopefully have some more information on it soon.
Fantastic.
It's Shi here. I believe that Monash and also Royal Melbourne, I believe that you guys only service your patient within your catchment. Is that right?
No, we service patients wherever that's our model is to look after patients who are inpatients of our service, and then to continue their care, we contract out to other services, but we continue their care. We're not too catchment specific.
So how you find that in terms of getting the level done for vancomycin?
Yeah, if it gets really difficult,
yeah,
and we have to change the dose. We sometimes, we just. Often we will contract out and we will ship bottles out or get them into clinic and get them to wait if we think there's going to be a bottle change. Yeah, we find workarounds all the time to that scenario. But if it's going to be really difficult for them to have vancomycin somewhere, we might transfer the lock, stock and barrel to a local service for their medical care and hand it over as well. We also do that if it's going to be better for the patient and easier. Yep.
Fantastic. That's a key theme, isn't it, of trying to find creative ways
around.
Yeah,
you just have to find a way that's going to work for the patient and it's going to be best for them. Yeah,
absolutely.
Yeah, so our creative way is to change the teicoplanin in the difficult ones.
Yeah,
and
we
that's
haven't done that. I'll remember that one for a future.
It's an easy one because you don't have to worry about this infusion over hours. It's just a 5-minute push.
We're slowly coming close to time. Siok, I think I can see you've got your hand up. Did you have another comment?
Thanks. Yeah, I had a question to Lydia around the ACID acceptance, I guess, in the Australian community around the DoseMe. It looks awesome. What should I tell my antimicrobial stewardship committee, really, is my question.
Put a business case in to get DoseMe. It needs a lot of pharmacy support and education to roll it out. We're still in the process of bedding it down at Monash, I guess you would say. So as I said, we did a pan rollout over the whole hospital, and it's still causing issues like with, you need a weekend pharmacist and you need lots of pharmacists to be on board with doing it. But in general, it's made it a lot easier in terms of dosing. And you don't have to do the major issue is much easier for the nursing staff, right? So they in the hospital, wherever you are, you can just take a level wherever they are. Doesn't matter if it's a trough level or a immediate post level or whatever it might be for intermittent or continuous infusion, and then you just plug that into the into the computer program. But it requires some education and pharmacy input.
I believe that we do have it. Alfred do have it.
Alfred do have it. I think they're just using it in ICU.
It's just that They only use it, correct. They only use it for a complex patient, where you can't actually get the prediction that well. And I believe that, unfortunately, I don't think I invited Kelly to come on, but I think she's probably, I'm not sure that she's on the chat or not. But I believe that we do have that program, that we do run it for a certain patient that is requested. Yeah.
Yes, it's been very good. I would advocate for it, but you need a business case and lots of pharmacy training.
Good to know we have the program though, so it might be something that we can have a look at further. Fantastic. Well, that's been a great discussion. Does anyone have any further questions or comments?
Are there any antibiotics I haven't mentioned that people use? I guess I didn't mention gentamicin, tobramycin much, and amikacin, but we do use all of those. But I guess aminoglycoside use in recent years, in the last 20 years, has gone down with basically side effects. I know there was that problem at St Vincent's Hospital where this is like 20 years ago, the court, a lot of, there was a court action against various things, various people, and that led to aminoglycoside use being significantly reduced. So we're all a bit cautious about aminoglycosides, and especially their balance and hearing problems.
Well, I might just finish up then with thanking Andrew for his time and for that presentation, and for everyone in participating today. It's been a really interesting discussion and lovely to see what different people are doing across Victoria. And I expect that some people will access the recording to see the session as well. Siok and I have been organising these sessions. This is only the second one, so do please provide us with some feedback in the comments or by email on the session about the timing and topics you might be interested in seeing as well. We'll aim to keep doing them. I think it's every 3 months or so.
Thanks, Archana.
Everyone.
Thanks.
Thank you.